Okay, so we're looking at the Google Classroom here again. So this is the documents we've prepared for today. There was the schedule. We've had the introduction from the previous participants in the course. And then we've got the ophthalmic pathology curriculum, the most up-to-date one. There's a set of notes here from the Eagle textbook, which is essentially the text from the textbook without the pictures that you might find useful. And then there's previous registrars have prepared past questions and notes on answers. Let's have a little look at those. Okay, there's two of them here. So they have discovered a whole lot of questions and answers, which is quite useful for everybody to learn from. But the talk that I'm going to give now is how to examine a slide. So let's open up how to examine a slide.
While that's opening up, could I mention that when we're talking in Zoom using the chat function, often there are comments going backwards and forwards, which is fine because we like to talk to each other. But if you want to ask a question, prefix your question with a question mark. If there's no question mark, it means it's a comment. If there's a question mark, it means that we'll address it as a question.
Okay, so Amanda's going to be monitoring the chat, so feel free to just butt in and ask questions. But if you want to ask a question on chat, then Amanda will ask me the question because I'm showing you the full screen here. Okay, so how to examine a slide. The first thing that we need to do is, oh, I think we're just flicking through these the wrong way. Here we go. The first thing that we need to do is we need to realize that every time the college asks an exam question, they are going to ask it in this format for the slides, where we have to identify the normal tissue and then this section here describe the pathology. So this is the big bit, right? This is the big bit that we have to address when we're learning to describe. Differential diagnosis, favored diagnosis, additional tests, and comments on the clinical manifestations. We may come back to this. So the first thing that we decide when we're looking at a slide is it a small biopsy or is it a globe? Because there are slightly different approaches to both of these. And when we're looking at a globe, we decide, is it a tumor or not a tumor? So if it's a tumor, then we start section B by answering these, okay? If it's not a tumor, then we start at the front and describe what we see. So two different approaches to describing a slide depending on whether it's a tumor or not a tumor. If it's a tumor, then the first thing we usually write in section B is where is the abnormality. The slide contains a tumor arising from the retina in the posterior part of the eye. The slide contains a tumor at the ciliary body, right? Where is the abnormality? We can expand that, for example, by saying the slide contains a tumor at the posterior part of the eye, which breaks through which arises in the choroid and breaks through Bruch's membrane, forming a mushroom shape. Okay? So where is the abnormality can be quite a detailed description of what you see at low power. We'll come back to the importance of low power momentarily. The second thing is what kind of cells are they? So now we're coming down to look at it at high power. One of the most common mistakes that trainees make is that they don't get enough out of the low power. okay? And they immediately go to high power and describe what kind of cells they are. So there is a set of key words that we use to describe things when they are benign versus malignant. So benign has words like bland and uniform in it, whereas malignant has things like hyperchromatic and mitotically active and pleomorphic and, importantly, invade. So what kind of cells are they? We might say that they are hyperchromatic pleomorphic cells that have numerous mitoses, and that would tell you it's malignant. And then, of course, for the specific type of cell that you're looking at, you might describe, say, the calendar classification of a melanoma, or specifically with a retinoblastoma that they form rosettes, etc. And then the third part of the section B of the description is what are the prognostic observations that you make. So, for example, with melanomas, you would talk about vascular and ciliary nerve invasion. You would talk about the approximate size. You might talk about where it is in relation to the anterior part of the eye, whether it's penetrated the sclera. There's one assumption that underlies all this, and that is that you have the base knowledge, okay? You can't accurately describe a slide de novo by yourself unless you know what you might expect to see. So this is why we start at the bottom with knowing. You need to do your bookwork first and know what to expect before you can make the observations. And in this course, we're going to help you make accurate observations. So it's important that you prepare for next week by learning the observations that you should make on lesions of the globe and of the orbit. Okay, so that's the knowledge that we expect you to come with. Because if you have never heard of the calendar classification, then you aren't going to be able to make accurate observations about what kind of cells that we have. Okay, so make the most of low power. Whether it's a tumor and where it arises, and where the main type of non-tumor pathology is and where the normal parts are. So we're addressing these first two bits here. Identify the normal tissue and start describing the pathology. All right, low power. Let's look at an example here. Okay, so what we have here is a globe. There doesn't appear to be a tumor, but immediately we can see that there is a funnel detachment, that there is a cup, that there is a really, really large area of subretinal exudate here. We can see that the lens has been pushed right forward into the anterior chamber. We can see that the retina is back here behind the lens, and there's probably the remnants of the iris here adherent to the cornea. So already we know that we've probably got something that maybe started as glaucoma and now has a massive retinal exudate and a completely disorganized anterior chamber. And we can write those down without even looking any deeper in. Another trick is to use the terms that you're used to using when you use the slit lamp. Okay, so you are used to describing things microscopically, just with a biomicroscope. So if you're describing things in the anterior chamber, feel free to use the terms that you would usually use when you are looking down the slit lamp. Let's look at another example. Okay, so this is another globe. What do we see? So is there a tumor here? No, there's not. So let's have a look at this starting from the front to the back. What we've got is the cornea. The angles appear open. The iris, it's not a transpupillary section. It doesn't appear to be very flat. It's a bit wiggly. So it's probably not glaucoma. The lens is present but not displaced. And then here we've got a lot of inflammation in the sclera. So we've got this big scleritis here. Yeah. And then round the back, the retina, it doesn't have a subretinal exudate through here, so it could have been artifactually detached. And here's the optic nerve. So here, identify the normal tissue and anatomical structures. Well, probably the cornea is normal. And then the sclera here, here, and here is markedly inflamed. The iris is probably normal. The lens is probably normal. And the retina and optic nerve is normal. So already at low power, we know we've got to work out what scleritis this is. And this is in fact a rheumatoid scleritis. Okay, here we go. So this is another example. So here we have a globe and it has a tumor in it, right? So here's the tumor. So we know that all of the anterior segment and lens and everything looks completely normal. Cornea, iris, ciliary body, angles, lens, sclera, and retina until the tumor are normal. We'd go and put those under normal tissues. And then we would describe the tumor. So where is it anatomically? Arising from the retina at the posterior pole is a tumor that is eosinophilic, i.e. pink, and extends as a dome shape into the vitreous space, right? The optic nerve is not visible. Okay, here's another example at low power. So at low power here, we can see that probably the normal structures are the optic nerve, the retina, the sclera, the choroid, all the actions at the front here. So what have we got? Starting at the front, we've got the cornea is perforated, the ciliary body and iris are adherent to the cornea, and the lens is prolapsing through a defect in the cornea. So already you are constructing in your minds a differential diagnosis, and that comes to part C and D, because at this point, when you've looked at low power, you start forming your differential diagnosis, and you know a bunch more of clinical conditions than I know. I'm sure that you could give a whole list of conditions now that, that give rise to this clinical appearance of a lens prolapsing through a cornea with a hole in it, more than I could. And then after you've formed the differential diagnosis in your mind, and remember you're allowed to use these, you're allowed to make notes on the side and write your differential diagnosis down, you can look intelligently at low power for confirmation of certain parts of a differential diagnosis. So that brings us on to C and D. Yes?
Before we move on to the getting to high power, while we're still on the low power, Chris has got a question.
Yes.
Maybe let's go back to that episcleritis.
Yes.
So on...
wrong way. Hang on.
The other way.
Yeah.
Or even that one. On low power, what's the easy way to tell if this mass is a tumour or not a tumour?
Okay, so fundamentally, there's a very limited range of intraocular tumours that they will give you, right? So if it's in the globe, you can't.
What could it be?
Yeah, it's going to be a retinoblastoma or a melanoma, basically, if it's in the globe. If it's outside the globe, it would be very cruel for them to give you a squamous cell carcinoma or a or some like rhabdomyosarcoma that was just in the orbit. But fundamentally, this isn't a tumor because it's in multiple places in the sclera. It's here. Oh, I've just tapped the slide again. Sorry, this is me being a bit, I shouldn't tap the slide. It's here, it's here, it's here. It's a diffuse process that's happening throughout all the sclera rather than a well-defined infiltrating mass. Do you think that answers the question?
Chris?
Yeah, it sounds good. Because I suppose like when I look at that, I think, oh, big yucky mass thing. And then compare that to the next slide where it's quite, you know, a well-defined, ordered, you know, something. Yeah. You know, I'd be inclined if I looked at that slide first off to say, yeah, but yeah.
So what about the staining? What about the staining and the color of the, like, the inflammatory cells Would that also be any help? Because this is more for eosinophilic.
Yeah. So, I mean, there's lots of purple in there because it's full of lymphocytes, which have got naturally a high nuclear cytoplasmic ratio. So usually tumors are purple. That's true. But sometimes masses of inflammation are purple too.
Yeah, thanks.
Yeah.
Okay. All right. So we're on to here. So how much can we get from here? So it's a lesion arising. So, right. So identify the normal tissue and structures. Well, here the cornea, angles, lens, and ciliary body look normal. What can we get from this? It's a tumor arising from the choroid in an adult because this lens is kind of flattish. So what tumors are purple and arise from the choroid? There's only one tumor that's purple and arises from the choroid in an adult, and that's a melanoma. So already you know the diagnosis. Making the right diagnosis here is not hard. So then what you've got to do is very carefully describe where it is, what the microscopic features are, and what the prognostic features are. So at low power, we can see a mass that is in the choroid at the posterior pole overlying the optic nerve that elevates the retina, and is accompanied by a subretinal exudate. Grossly, we can't see any penetration of the sclera, and the remainder of the eye looks normal. So even before we've started nipping down and having a look at those cells, we've got a good idea that this melanoma will be confined to here. But it's important to say all that at low power before you go on to high power.
Diane, for that slide there, I'm looking at the cornea. It looks a bit funny looking to me. Why isn't it smooth and dome shaped like a normal cornea?
Yeah, so, oh gosh, wouldn't it be great if we got a perfect slide out every time? Unfortunately, the slides are really hard to cut. There's a very technical process for producing nice globes that our lab uses a mixture of wax impregnation that involves beeswax and ordinary histological wax to actually get the right mixture to support the eye. But this has just become wrinkled during the cutting process. You can see the wrinkles. So one of the hard things to do is to identify what's artifact and what's not artifact in globes. So we'll give you nice examples pretty much. And in the exam, they will choose nice examples. But as we go through, we'll point out things that are just faults of the processing. Okay. Right.
Oh, and here's a question from Nishan. Do you want to talk to that directly, Nishan? That's good on this slide.
Yeah, so you know, on the previous slide, the total retinal detachment, I presume that was a regmatogenous because there was no mass, but that still had subretinal exudate. And this is probably an exudated retinal detachment with the mass, and that also has subretinal exudate. So histologically, apart from finding a tumor, is there any other way of telling what type or how the retinal detachment occurred? And I guess my third question would be if you get someone with proliferative diabetic retinopathy with neovascularization everywhere, can you tell a fibrous retinal detachment as well? Tractional retinal detachment.
Okay, so let's talk first about real retinal detachments and retinal detachments due to artifacts. So there was one back here. So I thought this was an artifactual retinal detachment. And if we look here, we would see intact photoreceptors. They would just look as if they'd been torn off, but they would be basically intact. Whereas a true retinal detachment has got loss of photoreceptors. So the first thing is it artifact or is it real? And the photoreceptors will tell you that. The only way you can tell the etiology of a retinal detachment is looking for the associated pathology. So for example, if this was a diabetic eye, we would see the fibrovascular membrane across the anterior part of the retina, and we would see neovascularization. So we would be able to probably work out that this was a tractional retinal detachment And so if we see a tumor and we see a big exudate and retinal detachment, we will know that there are leaky vessels in this tumor causing it. So it's about finding the associated pathology rather than anything to do with the exudate that helps us tell the difference.
Thank
Is
you.
that helpful?
Yeah.
Yeah.
So can you show me that photoreceptor thing again for the artifact?
Okay, so you can't see it at low power. I will show it to you, but not at low power. I'll make a point of highlighting it when we come to a good example of something that's been artifactually taken out. All right, so how you approach a slide is determined by what you see. So you have to look really, really carefully at low power to determine what you're going to do next. So if we have, now we're going to zoom down a bit, right? So this is the next step. We've observed what we see at low power. And if we see a large tumor, the next thing I usually do is nip to the tumor. We want to get writing about the tumor. Where is it and what type it is? Fortunately, you only have two choices pretty much. And then we describe something called the architecture and the cellular morphology. So the architecture describes how the cells relate to one another. I'm sitting here looking at a tiled driveway out my window, and the architecture is kind of how the cells tile together. So they could stream in long fascicles, yeah, or they could form a sheet. Now, this is particularly important in melanoma because if they stream together, then you know it's probably going to be a spindle B. And if it's a sheet, it could well be an epithelioid. The architecture in retinoblastoma, for example, is often one of a vessel surrounded by live tumor and then necrosis and calcification. If you go a bit closer to the architecture, it's got little rosettes. So the architecture is how the cells fit together in their jigsaw. And then we usually describe the cellular morphology. And that's where we talk about whether or not there's hyperchromatism, pleomorphism, what the cytoplasm looks like, whether there's pigment, whether there's numerous mitoses, the actual cells themselves. After that, we talk about staging and prognostic factors. That means you have to have a good idea of what the staging and prognostic factors are. So, you have to know that there's optic nerve invasion, scleral invasion, that there's invasion of the nerves and vessels in the sclera, that neovascularization is often associated on the iris with tumors, and tumor in the trabecular meshwork has a poor prognosis. So you actually need the book work of knowing what the prognostic factors are to go and look for them. And then we look for associated changes like the subretinal exudates, which aren't a prognostic factor, but are there. So this is the schema for looking at a tumor. And we'll run you through this lots. Okay, so once you've described the tumor, just start at the front and check, right? Check the obvious things. Check whether there's anything extra happening in the cornea. Is it edematous? Check whether the angles are in fact open and what the trabecular meshwork looks like. Just check. And always use your big advantage, which is your clinical knowledge, okay? You will have seen melanomas clinically. You know what they look like when you look in the eye. You know the staging factors when you're actually working in practice. And because what you see in the eye is so intimately related to the histopathology, you can kind of translate it. So applying your clinical knowledge will give you the differential diagnosis and the favored diagnosis. Okay. So the most common eye that you're going to get that isn't a tumor is going to be a glaucoma. And the key thing is to recognize it's probably a glaucoma at low power by observing the cupping. And then you know there are 12 common causes of glaucoma. So your next step is to look for the cause of the glaucoma. Now, I know that you do this clinically, you determine whether the angle's open or closed, and you proceed from there. You look at the lens. Okay, so 1, observe the cupping. 2, observe the cause of the glaucoma. Look for antecedent pathology. Is the lens horribly cataractous and dissolving? Is there a bunch of diabetic neovascularization? Then hop to the back and look for the secondary changes of glaucoma, the cupping, the ganglion cell loss. Do this in a systematic way so that you can put it all together at the end, okay? So often with glaucomas, you're fishing around a bit at first, trying to work out what causes it, and then you've got it, and then you go to the back of the eye. Okay. Right, sometimes you still don't know what it is, right? So it's getting the maximum amount of points possible. Don't panic. Start at the front and describe what you see, because you know what it isn't. Right, at low power, if you can't see a tumor, you know it isn't that. It might be a glaucoma where the cup hasn't formed yet. So start at the front and describe what you see, and you should eventually have enough facts to put it together. And remember, you've probably seen this pathology through the pupil and read about it in the textbook. So if you're able to make accurate observations, you can put it all together. Okay, so I'm going to pause and ask Amanda, have any more questions come up about globes?
No, please continue.
Continue. Right, so fortunately, looking at small biopsies from the skin and conjunctiva is simpler. Right. So the first thing you need to determine is what is the site. So look for clues if you're not told. It's important to be able to recognize the difference between skin and conjunctiva histologically. They are quite different, and I'm sure you've done the histo paper and can tell me lots about goblet cells in conj and skin adnexy in skin. If not, when we do this in week 3, then I'll run that through that with you. It kind of starts the same as the globe. Where is the abnormality? In the epidermis, at the junction between the epidermis and dermis, or in the dermis, okay? And what normal structures can you see? So, you know, in the globe, different pathologies happen at different places. It's the same in the skin. So most importantly, we want to identify whether things are confined to the epidermis or whether they're invading into the dermis. Step 2 is what kind of cells are they? Are they squamous cells? Are they basal cells? And then, are the cells benign or malignant? And this is where we apply our knowledge. We look for mitoses and we look for hyperchromatism and pleomorphism. And then we make other observations to support our diagnosis. So for example, we might have a big lump of purple cells that is in the dermis, that's got lots of mitoses in. We suspect this is a basal cell carcinoma. And we know, because we've learnt it, that basal cell carcinomas often have separation of the cells from the adjacent stroma with mucoid material in between. And we purposefully go and look for that. And then, of course, we talk about the prognostic features, like whether it's excised or not. Okay, so other things you might look for are melanin, for example, if you think it's a nevus. But what's important is that you can recognize the basic cell types, you know, melanocytic, squamous, basal, and inflammatory, and that you know the range of diagnostic possibilities. So again, in prep for week 3, you need to learn the range of diagnostic possibilities that you might see on biopsies from the conj, lid, and skin. And you remember, you have seen these. You have seen these in real people all the time, so you do already know that. The biopsy of the orbit is very similar, okay? Where are you? Is normal tissue present? What type of cells are they? And then the orbit, we often think, are they small blue, gland forming, or spindle? Then again, look, is there pleomorphism, mitoses? In other words, are they benign or malignant? construct a short list of diagnoses and look for specific clues. For example, if you are in the orbit, in the lacrimal gland, and you have a tumour, then realistically, there's only two tumours it's going to be, adenoid cystic or pleomorphic adenoma. So you can look for specific clues if you know them, but you do need to have learnt what to look for. Okay, so that brings me to the end of that talk. I'm going to stop sharing, go back to everybody, and I'm just going to stop recording.